Firstly, thank you so much for the invitation to come and speak at this conference. I've been coming to SexRurality over many years, and congratulations to Sersh and the team, and thank you, because this is such an important conference to have. So today I'm going to talk about what's really happening in STIs in terms of their epidemiology and provide some updates on where we can move to for STI testing in the future. So firstly, I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of the unceded lands on which we work, learn and live, and pay my respects to their elders past and present. So today I'm going to give an overview of what's happening in terms of STI epidemiology and where possible compare between rural regional data and metro data. Talk a little bit about the updates on the STI testing guidelines, and then look at new options for STI testing. And a lot of what I'm saying today you already know, so and thank you, you're already doing so much of it. So chlamydia, as we all know, is the most commonly diagnosed bacterial STI across Australia. Rates have been steadily, they've increased over many, many years, and over the last decade they've been fairly stable. We had, after a dip in COVID, we had 110,000 cases diagnosed in 2023, but we have been seeing a little bit of a change in who's being diagnosed with chlamydia. So in the past, it was the majority were in women, but in 2023, it's now almost 1-to-1. And that's probably because we're seeing a lot more testing among men who have sex with men, largely those taking PrEP for HIV prevention. And because of that, we're also seeing changing in the age profile. In the past, most people were in that under 30-year-old age group. It's dropped now to only 67%. So some changes happening in chlamydia. This data here shows a breakdown of the chlamydia diagnosis rates by geographical region. The remote in the red, remote and very remote, you know, your far North Queensland, Northern Territory and WA, as we all know, our STI rates are terrible in those regions. So about 2 times higher for chlamydia in the remote areas. Major metro and regional rates, the rates have been fairly consistent between those two areas over the last decade. Now this figure is a little bit harder to get your head around. Each of those shaded areas is a local government area, and this is all stuff that you can get off the Victorian Department of Health website. But what it does show is that we know rates are always highest in Melbourne, particularly Yarra and Melbourne, and that's where the populations are youngest, and we've got the higher proportions of men who have sex with men living. But in rural Victoria, regional Victoria, rates are highest, this was in 22-23 in the Wodonga region, Greater Shep, and also in Mildura. So looking at gonorrhea has always kept increasing over the last decade. Rates have always been higher in men than in women, largely because it's men who have sex with men that have propped up a lot of those diagnoses. But we're seeing a lot more now increasing rates amongst heterosexual populations, as we can see here in the women, with rates increasing quite steadily among women over the last decade. Where we're seeing them, once again, highest in the remote and really very remote areas, and steadily increasing and fairly similar between major cities and regional areas. When we look at Victoria, rates are highest in Melbourne, and if we go to regional Victoria in 2023, rates were highest in the LGAs of Mirrabul, for example, Mildura, and also in the Macedon Ranges, just to get you an idea of how rates vary across the state. The next thing I wanted to touch on was infectious syphilis, and we've seen a lot of change in syphilis over the last decade. It's usually been an infection that's been more commonly observed in men, and rates have continued to increase over the last decade. But of concern, we're seeing increasing rates among women, as we can see here. In a study that was published in MJA a couple of years ago, or last year, they looked at the notification rates of infectious syphilis for women of reproductive ages and broken down by region. And this top figure here is among our Aboriginal and Torres Strait Islander populations, and you can see rates highest in those in remote and very remote areas and increasing. And among the non-Indigenous rates, yes, our rates are about tenfold lower than what we're seeing in the Aboriginal populations, but we're also seeing dramatically increasing rates over the last decade and very similar increases between regional rural areas but also metropolitan areas. In Victoria, these are data for 2023. Rates of highest in metropolitan Melbourne, but in terms of LGAs, we've seen higher rates in Benalla, Murrindindi, and also in Hepburn. Now, because syphilis, we're talking about small numbers, there's a lot more movement here, so these rates in the regional areas will go up and down quite easily over time with even just one additional case. Now, this figure here is a bit hard to get your head around. So this is notifications of congenital syphilis between 2016 and 2024. And these data are terrible, and I know you all know about these in this room. These bars here are among our Aboriginal and Torres Strait Islanders, and these reflect number of notifications each year. And these here are among our non-Indigenous people. But looking over here, we've had 99 cases over this time frame. 14% of the non-Indigenous cases were in regional areas, and we had 33 deaths. So these really reflect a real failure of syphilis control in this country. And Australia is a high-income country, so we just should not be seeing this. So these changes in STI patterns, chlamydia being more stable, growing rates of syphilis and gonorrhoea, particularly among women. We've seen changes in our national management guidelines. And I've talked at this conference before, and a lot of my research has been about chlamydia in the past, and I've constantly banged on about chlamydia. I think now we're shifting away. There's less emphasis on let's do lots of chlamydia screening in women. The guidelines now say any time you order any chlamydia any test, that must include both HIV and syphilis testing. So we really need to, every time we think about STI testing in anyone, make sure we do HIV and syphilis as well. And as we saw yesterday, because of these syphilis rates, we've seen changes now in the syphilis testing guidelines for pregnant women. 3 tests are now recommended. First antenatal visit, 26 to 28 weeks, and at 36 weeks of birth as well. So what can we do about changing STI transmission in the population? And STI transmission is a function of 3 factors and represented by this equation. And this is the reproductive number equation. And if you remember back to the COVID times when every night we'd have one of the mathematical modellers on the TV telling us what the reproductive number of COVID was, you had to keep it, if it was going above 1. This also applies to chlamydia, to STIs. And when we look at the particular factors, we've got beta is how infectious, how easy it is to spread the infection. So whacking on a condom, using vaccines or doxypep, that can all reduce the transmissibility. C, partner change. By reducing the number of sex partners, we can reduce STI transmission. And D, duration of infection. By getting quicker access to testing and treatment, we can reduce transmission of infection. And as researchers and policy people, when we're thinking about what interventions we should be targeting for STI transmission, we tend to focus on this because it's hard. We still don't have the vaccines. It's hard to get people to use condoms, and it's hard to get people to change their number of sex partners. So looking at access to healthcare, this is critical for control of STI. And as we all know, in Australia, most STI testing happens in primary care. It actually happens in general practice. Our specialist STI testing services are at capacity. And as we all know here, and we heard again yesterday, there are considerable barriers to accessing healthcare, particularly for those living in rural areas. And I won't go through all of these because of time. So there are some new options available for STI testing, different ways to try to reach people or make it easier for people to have STI testing. We have telehealth, which Patty just mentioned before. That was one good outcome of COVID. We have online STI testing. We have the STI vending machines. We have point of care tests, and we also have tests you can buy online and do it all yourself and interpret the results at home. I'm going to talk a bit more about these now. So in terms of telehealth, as I said, one positive of COVID, a person now can phone up, have a GP consult, be sent an electronic pathology test request, get an e-script if they test positive, particularly for chlamydia. They'll still have to come into a clinic for gonorrhea or syphilis testing. And the great thing about this is that the person does not have to have an ongoing relationship with the clinic, so they can go to any services theoretically to have a telehealth consult. New South Wales sexual health clinics have done a great job at looking at how they can implement telehealth into their services, and they've set up the MyCheck system. And this is available, it's being increasingly rolled out across all of New South Wales. So it's only available for existing clients of the service who require asymptomatic screening. So they have a telehealth consult, get sent a pathology test request form, they then have to go to a pathology provider for specimen clinics and attend a clinic in person for treatment. So they've done some evaluation from this, and here are two quotes from this. The one on the left in blue is a more positive quote, and the one on the right is a little bit more negative. So the person on the right said that, you know, it was a 5-minute drive, so it was quicker to actually get to the pathology provider than attend the clinic, and they could do their grocery shoppings at the same time. However, in the one on the right, which is something to consider about, because she was attending a pathology collection, a mainstream pathology collection centre who may not be used to seeing patients presenting or requiring all the different kinds of sampling you need for a good STI screen. So this patient felt it was awkward and was quite stressed. So that is something we do need to think about with how we can support mainstream general pathology collection, because we are going to see an increasing use of telehealth and online screening where patients have to interact with mainstream pathology for their testing. So then online STI testing services, and these have really exploded over the last 5 years. So we all know there's quite a few of these available in Australia now, but essentially you sit down at the computer, you set up an account, you'll be asked a series of questions about your sexual health. They're all anonymous, you just type them in, it's all automated. You get sent either a test kit to do it all at home and post it in to a lab, or a test request to go to a pathology provider. Results provided electronically. Treatment can be provided electronically through the post, or patients are required to come in for testing. Now the UK have been big users of this, and the UK government actually funded the initial setup of SH24. This was an online STI screening, or actually an online sexual health service that was used to support their GUM, or their genitourinary medicine clinics. And now they're using these SH24 clinics across the UK for providing a lot of STI screening and sexual health service. They did a clinical trial of this back about 7 or 8 years ago to see how well it works in a couple of pockets of London. People were sent an invitation to either do it online or come into the clinic, and it really did lead to a significant increase in testing, which was great. But there was no difference in the time to treatment. People still had to come into the clinic for treatment and had to get appointments, etc. Get Checked Online is another great online system that's been rolled out in Canada, and that, as you can see here, the number of people using this has steadily increased over the last decade or so. Push. Yes. But these systems, there are equity issues and there are risks. There was a systematic review published a couple of years ago looking at a number of online clinics and how they worked. And it found that the users of these services were more likely to be white, higher socioeconomic background, urban, women, and slightly older. They also identified a number of risks. One, it was unclear how these services managed at-risk users, particularly at younger age, because it's hard to stop underage people using these services. How do they identify and manage sexual assault in users? They were missing vulnerable risk populations. They were missing people from non-English speaking backgrounds. They were excluding those with disability or poor literacy or poor health literacy. And there was a delay. There were the checks about how you make sure someone who's diagnosed is treated was also unclear. So as a result of this, Trey Caldwell, a PhD student with us at Melbourne University, decided to have a look at, well, what's happening in this space in Australia? And in about 2001, he commenced a review of online STI and HIV testing services in Australia. And he identified 17 services at the time. Now, there'd be heaps more now if you went back and repeated this. He found that of those services at the time, 2 required self-sampling. They sent a test kit to your house, you collected the specimens and posted them in. 7 sent you an electronic test request, so you had to front up to a pathology provider. And 8, you could order a test kit sent to your house, do it all and interpret the results yourself at home. So while there were some good services amongst these lists, there were also some limitations. Only 4 of the services tested for the recommended all 4 STIs. Not all recommended the swabs of the genital, anorectal and oropharyngeal, so that meant a lot of people would not be getting the correct and appropriate screening. Some offered tests not recommended by the guidelines. Most of the self-tests that you could get at home and do it all yourself were not approved by the Therapeutic Goods Association, and to be honest, most of them are pretty crappy tests, so you're going to get an inaccurate test result. Some of them offered weird testing as part of their routine STI panel, like uroplasma testing. The cost varied from $0 up to $595. So there were potentially equity issues there as to who could afford to pay and what they would get. So this led us to have a little bit more to look at about whether or not online testing, how it could be used, particularly to increase access to testing in rural regional area. And we conducted a survey of 1,000 young people to look at their preferences, and we found that most said that they would prefer online testing. Interestingly, those young people living in rural regional areas, and about 30% of this sample lived in rural regional areas, they said that they would prefer online testing. But however, those from culturally and linguistically diverse backgrounds across the whole 1,000, they said that they would prefer to test in person rather than online. So that's something to also think about. In some work that was done by SEARCH more than a decade ago, so SEARCH was onto it before everybody else was. They did some focus groups with young people and found it was very acceptable, but the young people didn't want a specimen collection kit being sent to them, and they were concerned about the cost. And here are a couple of quotes from our survey. So the one on the left was from a rural person saying that they'd be the first to get tested online if this was available, and the one on the right was from a metro person. So this work we managed to get some money to develop an online STI testing service that is linked to Melbourne Sexual Health Service. So it's a Melbourne Sexual Health Service service. And Lauren Ware actually did a great job of presenting some information about this yesterday. The key things with what we've been doing is that we've co-designed it with young people, 16 to 29-year-olds, and particularly young people living in rural and regional areas, because while the service will be available to anybody, we thought this is a group of people that we want to make sure it's a service that has a look and a feel that might be attractive to them. And we're doing this in partnership with all the partners you can see down the bottom, but of particular note, Health Department, Sexual Health Victoria, and also SERSH as well, and Youth Affairs Council Australia. And this is just what Lauren showed yesterday. We're launching it in 2026, so hopefully in a couple of years' time, we will have some results to present. And I just want to thank, I know we've been talking to a lot of people probably in this audience who've really helped us understand the issues and have input to its development. So the next thing is looking at STI test vending machines. And SERSH and Kim Cowan and Dave Evans have done a great job setting up STIX. And this is Australia's first vending machine providing chlamydia, gonorrhea and HIV testing, free tests for people in particular risk groups. And there's an example of this sitting where we have lunch. So I had a bit of a play yesterday. I encourage you to have a play and get your test kit. Point of care tests. Now, point of care tests are where the specimen is collected and can be tested at the same time. So they provide rapid testing and diagnosis at the point of care, and they're fantastic because they can reduce the time between diagnosis and treatment. Because if you imagine if you're in rural, remote Australia or even in parts of Victoria, the specimens you collect have to be couriered back to the lab. So it can take days and weeks to get the test results, during which stage anybody with infection can continue to transmit. And Rebecca Guy from the Kirby's done some amazing work with implementing point of care tests in remote Aboriginal community controlled health organisations. And they're providing results in 2 hours, and they've significantly reduced the number of infectious days, which is amazing. They also have managed to get a Medicare rebate payment specifically for these tests in remote and regional areas. So this will have an impact on what we see in STI transmission in the future. The one limitation about rolling this particular test methodology out is it is limited to one specimen at a time, and a lot of our clinics we're testing multiple patients a day, so it's not cost effective. Self-testing. If you were to log online today, there are thousands of tests that you can get sent to your house and do your test yourself. Most are not TGA approved, and most are going to give you an inaccurate result. However, late last year, the TGA approved a self-test kit for chlamydia and gonorrhea. This is now available in Australia. However, it is only for vaginal infections, and it's only for chlamydia and gonorrhea. So these tests can be great, increased access to testing, but there are disadvantages. Missed opportunity for that consultation, missed opportunity for syphilis and HIV testing. And if you get a negative result and you're sitting at home and you think, okay, I'm okay, even though I've got my symptoms, we still, as you know, need to follow up these symptoms. So just to finish up, we all know STIs continue to increase. They're increasing in rural and regional areas. And we all know syphilis is now a huge problem. Congenital syphilis just should not be happening. While the focus, particularly among women of reproductive age, has been on chlamydia for years, we really now need to shift that. It's syphilis, syphilis, syphilis. Our testing guidelines have changed. Access to affordable, acceptable and culturally appropriate sexual health care is critical, but we all know there are increased challenges for access in rural regional areas. We need strategies to make it easier for STI testing in general practice, and I haven't really gone into those today. But this does include some digital interventions, changes to using the electronic medical records more appropriately, and a real thing is new funding models. And we all know the funding models, particularly for sexual health service delivery, aren't great in primary care. Point of care and self-tests, fantastic, but require careful implementation and strategies to minimise their risks and limitations. Digital health is going to expand dramatically. There are AI apps happening now that you can take a photo of your genitals and send it in and get a diagnosis. We're going to be seeing more and more and more of this. Something for you to think about, Patty. But the big thing with digital health is there are huge inequity issues. Not everybody can use it. So if we're going to rely more and more on digital health in the future, which we will be, we have to think about how do we reach vulnerable populations, those at risk. And finally, just a thank you. And this is a photo of Mount Sturgeon because I grew up just near there. So thank you, everybody.